shall talk on destructive surgeries in obstetrics. What is the purpose of destructive surgery? These are surgeries designed to diminish the bulk of the fetus so as to facilitate easy delivery through the birth canal. In modern obstetrics, it is not actually feasible because it has got psychological effect on the mother and also her family. There are certain litigation problems and complications are often life-threatening. Contraindications to destructive surgery are: in case of living normal fetus, it is not performed; if the pelvis is markedly contracted; if the cervix is less than 3/4 dilated; in any kind of neoplasms obstructing the pelvis. The dangers that we may be faced with are lacerations of the vagina, cervix, uterus, bladder or rectum. There may be uterine rupture, hemorrhage from lacerations or from uterine atony, and infections. There are 4 main types of destructive operations: craniotomy, decapitation, evisceration, and clavicle. The commonest one is craniotomy. What is craniotomy? It is an operation to make perforation on the fetal head to evacuate the contents inside the fetal skull, thus reducing the size of the fetal head, followed by extraction of the fetus. Indications of performing a craniotomy are obstructed labor with a dead fetus, hydrocephalus, live or dead, especially unfavorable position of the child, as in case of impacted mento-posterior or brow presentation or occipito-posterior position following a prolonged labor, and in case of interlocking of twins. Prerequisites are: the fetus is to be dead except in case of hydrocephalus, where it can be performed in a live fetus as well. Then 2/5 or less of the head palpable above the pelvic brim. Head is impacted, cervix is at least 7 cm dilated, but preferably it should be full dilated. Uterus should not be ruptured, and also there should not be any features of imminent rupture of the uterus, and the true conjugate should not be less than 7.5 cm. Pre-treatment: we are to correct dehydration of the mother, treat ketoacidosis if present, blood should be kept for cross-matching and also for investigations, arrangement of blood should be done, prophylactic antibiotics are to be given, and the bladder has to be catheterized. What are the sites for perforation? In case of forecoming head, it is the parietal bone which we perforate. Then in aftercoming head, as in breech presentation, we perforate the occiput and occiput or the lateral fontanelle. Then palate or orbit in face and the frontal bone in brow presentation. Anesthesia used may be either general anesthesia or spinal anesthesia with IV sedation. The first step in craniotomy is perforation, which is performed by using an Oldham's perforator or Simpson's perforator. The head of the child is steadied from above the symphysis by an assistant grasping it and pressing it against the pelvic brim. The operator holds the perforator in his right hand, and under the protection of the fore and middle fingers of his left hand that is placed in the vagina, the point of the instrument is directed up against the skull and pushed through it at right angles to the surface of the fetal skull. The blades of the instrument, having been pushed through the skull as far as the shoulders, should then be separated by pressing the handles of the perforator together. The instrument should be turned round and a similar tear should be made at right angles to it. The points of the instrument should be pushed into the skull and the brain churned up and broken up in all directions. Next, the instrument is withdrawn under the protection of the left hand of the surgeon. Next we go for extraction, which may be left to natural forces, or we may apply forceps or valsalum, or use instruments like cephalotrip or cranioclasm. In case of hydrocephalus, perforation can be made by any suitable sharp instrument, provided the cervix is sufficiently dilated to allow at least 2 fingers to be introduced. After perforation and collapse of the fetal head, spontaneous expulsion of the fetus in this case is generally quick and easy. The complications are, there may be injuries to the various organs like bladder, urethra, vagina, cervix, uterus, rectum and intestines. Injuries to soft tissues and hemorrhage. It is always important to rule out rupture of uterus both before and after performing craniotomy. This is a diagram showing craniotomy. Next we come to decapitation. Indications are, it is performed with neglected shoulder presentation with hand prolapse and in case of interlocked twin. The prerequisites are, here the neck of the fetus should be easily accessible per vagina. There should be no evidence of impending rupture and cervix should be at least 7 cm dilated. The fetal neck is severed using a thimble and a wire or with decapitation hooks. Once the head is completely severed, the trunk is removed by traction that is applied on the arm. Next, we remove the severed head, which is accomplished by a finger hooked into the mouth and pulling on the jaw or with forceps. Should the pelvis be contracted, the head is steadied by suprapubic pressure, perforated and then removed with the cranioclast or crochet. This is a diagram showing decapitation. Next is evisceration. This is performed in a case of neglected shoulder presentation with dead fetus where the neck is not easily accessible, and in cases of fetal malformations like fetal ascites or monsters. It consists of removal of abdominal and thoracic contents of the fetus with the object of diminishing the bulk of the child, permitting it from being extracted. Special care should be exercised if the fetus is large or the cervix is inadequately dilated. It is particularly performed in monsters and where the abdomen or the thorax of the child is distended with fluid or a tumor. This operation is performed by making a large opening with a perforator either into the abdomen or the thorax. The viscera are then broken up and removed manually. During these manipulations, if the lie is transverse, the trunk of the child may be steadied by pulling down an arm. Then we come to cladotomy. Also it is known as division of the clavicles. It helps to reduce the bulk of the shoulder girdle of the fetus. It is particularly done in case of shoulder dystocia in dead fetus. 2 fingers of the left hand are passed along the ventral aspect of the child, and under protection of them the long straight scissors is introduced and the clavicle divided. Considerable power is required to snip the hard bone. There is danger of injuring the soft parts of the mother. Also, care must be exercised in identifying the position of the clavicles. Morcellation is cutting the fetus into pieces, which is necessary on rare occasions before vaginal delivery is accomplished. Then there is a term called spondylectomy, which is transection of the spine of the delivered thorax. In breech presentation, it may allow drainage of CSF. It is done when the back is anterior and the head and neck are both out of reach. In case of hydrocephalus, where there is communication between the ventricles and spinal cord, the fluid may be drained from brain in this way, obviating the need for craniotomy. Post-delivery care, active management of third stage is to be done. Oxytocin infusion is to be continued for 6 to 8 hours as there is high risk of having atonic PPH in such cases. Also, careful inspection of the genital tract for signs of trauma should be done, including uterine exploration to rule out rupture of the uterus. Bladder should be catheterized for 5 to 7 days in cases where the lady had prolonged labor. Then you should go for using broad spectrum antibiotics and thromboprophylaxis. Psychological well-being of the husband and the wife and family members should be taken care of.